This is CCTA Case 31. The history is a 66-year-old woman who has had some chest pain in the past but also has a history of atrial fibrillation. She is undergoing pre-operative assessment for possible pulmonary vein ablation therapy. This is a single-phase image, and even though you will clearly see there is some coronary disease and some atherosclerotic plaque, the single phase for this study is insufficient to completely evaluate the coronary arteries. In this example, we're now looking at the other characteristics that the electrophysiologist would like to know prior to proceeding to pulmonary vein ablation. The first thing is they want to look at the left atrial appendage. So let's focus here in this area, and we'll see that this is the left atrial appendage. Now, you can see contrast, but look at this outline up here. This is not opacified very well, while the other area is very well opacified. However, it is somewhat opacified. So the best way to look at this is to look at CT Hounsfield numbers. If we look at the region of the left atrial appendage, we have excellent opacification, but if we proceed to the area that also appears to have some reduced density, we're getting densities of 100, 134, 97. These are higher than tissue densities, so that means that there is partial filling of this area. Now, part of the problem is that separating thrombus from pseudothrombus, which means that we haven't imaged late enough in the cycle to see good enough flow into the upper parts of the left atrial appendage. So very slow flow in patients who have atrial fibrillation, and frequently if we took the images maybe 5 or 10 seconds later, we would actually see this area fill in with contrast. So this is what's called a pseudothrombus. If this is of concern, then the patient probably should have a transesophageal echocardiogram. But in this particular case, there clearly is some flow into that area, so it's not absolutely a thrombus, but you remain with some difficulty in the clinical situation. Now let's delete this and start looking at the other characteristics. So we want to identify several things. First of all, we want to determine how many pulmonary veins there are. Right caudad to the left atrial appendage is the left anterior superior pulmonary vein, which I'm demonstrating right here. If we look at this, we can actually rotate down 90 degrees. That is, we're rotating in this direction, and almost always you'll get to see also the left posterior inferior pulmonary vein. Now, one can make a variety of measurements. Two-dimensional measurements can be done here of this area. This looks like this is about 14.5 millimeters. We can make another measurement here from the left posterior inferior. We're getting about 12 millimeters. These are fairly normal values for this. I'm going to delete these now. So we found two left pulmonary veins. Let's go back to the foot view and start looking at the right pulmonary vein. So the right superior pulmonary vein is right here. So let's get that identified. If we do the same thing, we kind of rotate 90 degrees posteriorly, we can actually see the pulmonary veins on the right side come out reasonably well. So there is a right superior anterior and now also a small right middle pulmonary vein, as well as a right posterior inferior pulmonary vein, and you can make measurements of these to get nominal entrance diameters. Another feature that the electrophysiologists are very concerned about is that usually if they need to do a pulmonary vein ablation of the right posterior inferior pulmonary vein, they want to have an idea of where the esophagus is. Now, the esophagus is over here, and if you can't figure out where that is, start going down caudad until you start seeing, yes, this is the esophagus. Clearly this is the issue. And as we go back up, we can see that this is quite a distance from the right posterior inferior pulmonary vein. So if you're doing an ablation in this area, it's very highly unlikely you're going to worry about what happens with the esophagus. The final thing they would like to know, okay, in this instance then, we want to play M-mode echo cursor. Let's focus in the middle of the left atrium, and then try to determine where it's nominally the largest, roughly about this area, perhaps here. One can then begin to measure this by making a simple two-dimensional measurement. Again, playing M-mode echo will come from the left parasternal view. Approximate that and try to make some reasonable assessment of this area. I'm getting about 36, 37, 38 millimeters, clearly not significantly dilated. So for evaluating studies for the electrophysiologist, you need to look at the left atrial appendage, determine if it's normal or whether or not there's a potential for a thrombus or a pseudothrombus. You need to identify all of the main pulmonary veins. In this case there are 5, 3 right and 2 left. You need to look at the position of the esophagus to see if it's dilated, which it's not, and it's clearly quite separate from the right posterior inferior pulmonary vein, and you need to get a general idea of the anatomy and size of the left atrial appendage.